So last week I'm gonna try to avoid using a lot of diagrams and things like that. I hope it wasn't too confusing, but today I'm going to speak about opioids, which is a class of drugs that we use here to describe morphine and morphine derivative type drugs. And so I wanted to first talk about, last time I used a lot of big words, I wanted to talk about just some basic word, I guess, groups. Okay, so what is the term analgesia? What does analgesia mean? Sorry? Okay, the inability, right. So analgesia is the inability to feel pain, ideally, to feel pain. Okay, and we have drugs that we refer to as analgesics. And so what does it's not good common. So what does a drug, an analgesic drug do? It's not hardly. So it relieves pain, but it's a drug that relieves pain. But the key is, without the patient losing consciousness. Does that make sense? Yes. Yes. So they can still be sedatives, but by definition, they don't produce loss of consciousness. All right. So some other drugs, because we use the term opioid. So what does the term? Let's start with the term. What is opium? So opium. So opium is the original opioid. Opium is a mixture of drugs. It's a bunch of compounds derived from, you know what plant it comes from? From the Wizard of Oz? Anybody? Poppies, from the seeds of the poppy plant. I probably need to write this down, but from the poppy plant. And that was what was originally used from when, I guess, our forefathers, ancestors, realized that they could take that and feel kind of high and also feel pain, for pain relief, and they were used medicinally. So then, what's the term opioid? So what we're talking about. So we have opioid, which is the drugs that we're talking about. So an opioid is it's a substance or a compound, and it could be either naturally occurring or synthesized. That binds to a receptor. Okay. So we say binds to a receptor. Okay. So with the word receptor here, there are quote-unquote receptors in the brain and the spinal cord. There's subsets as well, but the ones that that are really relevant to us in almost all procedures in human medicine as well are these receptors in the brain and in the spinal cord. And so the ones that the drugs that we use, these drugs, these opioids, they're derived from opium in some way. These will act on, when we give these, they will come in and they will bind here or here, and the only one that binds to delta is the one that we use, we only have one that's to delta. Most of the time, so we talk about these are modulating pain. There are mu receptors in the spine and the brain, or kappa receptors. There are also delta receptors, but the drugs that we typically use do not work on delta receptors as a general rule. And so when we do this, when we give these drugs, as a general rule, kappa and mu all of these, kappa and mu and kappa and delta, all of these modulate pain. So all of these modulate pain and decrease pain. The mu receptors are also responsible for the untoward or undesired effects we see with opioids, such as panting, delirium, vomiting, crapping on the floor, respiratory depression. All of those are modulated by the mu receptor as well. So mu is the receptor for the strongest analgesia, but it's also responsible for some of the less exciting, the less flattering of the side effects that we see. And so the other term I wanted to ask you about to define, because it's important, because I always questioned it. What about the term narcotic? I want to ask you, hey, that drug's a narcotic. We've heard the term narcotic. So what does it mean when we say narcotic? In general. There's no wrong answer. So narcotic comes from narcos, which is the Greek word for numb, being numb. And so in general, so narcotic is generally a drug that we use to mean that it addresses pain. However, it doesn't mean that now in the context of like the pharmacy, when we go to CVS or Walgreens. Really what a narcotic is any drug that has the potential for dependency, that has the potential that acts on mood and behavior. Does that make sense? So narcotic doesn't mean something that knocks you out, which is why I found it very strange. So we think of narcotics as things that make you sleepy or knock you out, right? However, a narcotic means when you go to, if you're like ADD medication, for instance, is a narcotic, even though it doesn't make you sleepy, because it's a drug that has the potential for dependency and affects mood and behavior, gives you the term narcotic, which is why, but that is also why the narcotic drugs, including, I don't know why, things like gabapentin and tramadol, all of those potential to be, tend to affect mood behavior and have the potential for habituation as well. So the other word that I wanted to talk about, because I think this is important, is people talk about drugs as being look at drugs like morphine, hydromorphone, oxymorphone, buprenorphine. So we talk about drugs being agonists. So we say if a drug is working on the mu receptor, okay, this is mu. So if it's something that is stimulating the mu receptor, we say that it is a mu agonist. So it doesn't mean agony. An agonist means it's positive. Agonist means it is activating it, okay? But if let's just say we give another drug that is a negative, that we would say it's a mu antagonist, okay? So when we're saying, hey, I want to give a pain medication, if you want to give a dog pain relief, would you give it a mu agonist or an antagonist? If you want to stimulate the receptor, you give it an agonist. It's a strange word, but if you think of that antagonist as antagonism, so if you give something that antagonizes it, it's not going to work. Okay? So, but we use the term, we say, oh, it's an agonist or an antagonist. An agonist means something that stimulates the receptor, by stimulating the receptor, producing analgesia. If we give something like a drug, let's say we give a dog a ton of a drug, let's say methadone, and we're like, oh crap, we overdosed it. Then we give, there's a drug that reverses, it's a mu and kappa reversal drug called naloxone and Narcan. You've heard of that? That would be an opioid antagonist, right? So there's other drugs. So this is an agonist. So then there's something. So antagonist, and then without getting too complicated. So things that are mu agonists are generally the drugs that we are most familiar with. Meaning, I mean, in here at BCSG, meaning drugs like methadone and hydromorphone. Okay, so when we, this doesn't work from last week. How about I write smaller? Can you see this?
Actually left some like
There should be like a wet. Oh, she did. I forgot. Yeah, I can't find it. Anyway, and this is the only part that's pretty complicated. Just so when someone talks about it, you will have an idea of what's going on. And so there are not too many antagonists, but there are things that it's called a pure agonist. And then there are drugs, and if this doesn't make a lot of sense, we're good, because I can hide them. But this is more. So if I told you that I was going to give you some drug for pain, would you want a pure agonist or a partial agonist?
Pure.
Yes, exactly right. A pure agonist means when the drug binds to this, it will stimulate that drug maximally. It's a maximum stimulation of that. It'll stimulate a maximal response. Okay? Then there are drugs that are called partial agonists. So a pure agonist gives you a maximal response, okay? Which is why drugs like methadone and hydromorphone are so effective. They are pure agonists at that receptor. Okay. Then there are drugs that are considered to be things like partial agonists. So there are things that a partial agonist. Let me think. Drug. Let's see. So these are like I'll put this here for now. Methadone and hydro. Then there's partial antagonists. Drugs that are also will work on that receptor, but it's partial. So that means that it's less than maximal response when so it'll work, it will bind to the receptor and cause analgesia. However, it will not be as effective as a pure one. So the example here is buprenorphine. So buprenorphine is what's called a partial agonist. Okay. Then there are certain drugs that are both, that are agonists and antagonists. And so there's a drug, butorphanol. Okay. You'll have what we call torvigesic here. I'll write this all down again. So butorphanol, just so you know, it's a weird one. So it is a kappa agonist and a mu antagonist. Anyway, the bottom line is they all act on the brain, and I think if you understand that something that causes stimulation of a receptor is an agonist, stimulant. And I think the way I think about it is I just remember what antagonist means. Antagonist means it antagonizes the receptor, so it's not going to cause pain. Now, the drugs that we call antagonists, they don't really actually do anything. Like they are the only thing that they do. So if you have a drug that's let's say you have a drug that's an agonist like this, right? And then you have other drugs that are antagonists. So these drugs, they don't do anything. They don't like turn down. They don't like downregulate things. What they do is they just occupy it so the other one can't get to it. They don't do anything. They have no real effect. They don't downregulate the cell. All they're doing is preventing this compound from arriving at the receptor and doing what it's supposed to do. Does that make sense? Promise? Would you say something if it didn't? You wouldn't, I know, but please do.
Can you explain that last part again?
Absolutely. So, if you have, absolutely. So,
Like it's really good guy you can draw on the side.
No, it's okay. So here's the deal. Okay, so let's just say you have a receptor. This is your whatever, mu, whatever. So it has, as soon as this a drug, let's say, let's just say methadone. How does it work? It'll bind here. It'll then send a signal to release whatever's in whatever it is. Whatever, it's a complex process, but it'll tell the receptor when it blends there, provide analgesia, like pain relief. So this is what's called an agonist, but it's a mu agonist. But if you give at the same time, let's just say the very same time, you give this dog or cat a drug like butorphanol, which by itself does other things, but it is a mu antagonist. So the point is they're not going at it, like they're not like fighting each other like what they do is by antagonist, all it does by saying that when it binds here like that, all it does is it prevents the other ones from attaching. So if you have butorphanol sits here, okay, it's going to prevent pain relief because it's blocking the other ones. Does that make sense? So you have methadone and you have butorphanol, but the butorphanol will physically sit on the receptor where the methadone lands or sits, or where your oxymorphone and hydromorphone sit. So it doesn't have any chemical activity except it just sits there and blocks the other one. Does that make sense? And so basically, by antagonizing, it is antagonizing the effect of that drug. And so I just want to see. So the other thing is I thought we'd talk about is what are the advantages? So we use opioids a lot. And I thought, what the advantages of opioids, so what are some good things about using opioids in general? And then we'll compare the ones that we use. Okay, so one of them is analgesic. I mean, they're really good analgesics. They're not anti-inflammatory, but they're really good for pain relief. Most of them, cats versus dogs, will provide some degree of sedation. Depends on the drug, the species, and frankly, depends on the patient as well. Okay? And the other things that it does, and those are the good things, it also, the duration is variable. It does the other things it does is cause some respiratory depression and bradycardia. The bradycardia, you guys know what bradycardia is? Please say yes. If not. So Brady, bradycardia is a slow heartbeat. At doses that they should be prescribed, none of the opioids really cause bradycardia. However, in hypothermic patients, it's pretty dramatic. So when you have pets that are below 100 degrees, below 98 degrees, when you give them, that's why I try to wait until pets are above 99 before I give them the opioids. Not that they don't need it, but when they are hypothermic, did I say hypotensive? I meant hypothermic, I'm sorry. Hypothermic.
You said hypothermic.
Okay, so when they're chilly, when those animals are cold or chilly, that's when they tend to become more bradycardic when you give it. And so we have some, so the drugs that we use, I'll make a little, a chart. And so I'll put this mu agonist. Then the other one, let's say butorphanol. So this one, and these first ones, the only ones that are really exceptions. So this one works on kappa and mu. Again, kappa is mu, they're both pain. Okay, but this butorphanol is a kappa agonist. So an agonist means it's going to work on pain via that way, but it's a mu antagonist. And I don't think this has a lot of relevance, except neither of these are especially great analgesics. And the important thing to take home about these two things is that I don't have I don't have as negative experience with butorphanol. Buprenorphine, this is the key if you take nothing else home. Giving an animal buprenorphine and expecting it to work quickly is unrealistic. So if you have a blocked cat and the doctor gives it buprenorphine and propofol, on a good day, buprenorphine takes 22 to 30 minutes to do anything. So you give it before a stimulus. If the drug is in their system at the time of a painful stimulus, you're in good shape. In dogs, you cannot catch up with buprenorphine. You have a dog under anesthesia, under general anesthesia, it's moving. You know what you can do? You can give it methadone. You can give it fentanyl. You don't give it buprenorphine because it takes 15 minutes to do anything. It doesn't matter how you give it, IV, intrathecal, does that make sense? Buprenorphine in cats, I think it's great. I think it's really nice analgesic in cats. I'm not very impressed. I'm impressed in dogs if you get it into their system before them. It's a soft tissue procedure. But it is not, because it's a partial mu agonist, okay? And there's so much you can do, for lack of a better term. It's not a bad drug, but it has to be in their system before a painful stimulus. You can't really catch up. It's something, but when it's in, and it's not something like an orthopedic procedure, it works really nicely. The other drug is butorphanol, that everyone here has used butorphanol or torpagesic. So it's been around forever, well, since I was before vet school. And so there was nothing really else out for pain relief. So butorphanol is a kappa agonist antagonist. And so when you give it to animals, in cats, it's a nice mild sedative. I think, I'll tell you how I use it, and you can go from there. So it gets a bad rap because it's not especially good analgesic. It lasts about 45 minutes, maybe 50 minutes. However, the times that I will use it, and I stand by this, is if you have a pet, that you have a patient that is sitting there, and you're saying to yourself, gee, that dog is tachycardic. That dog is panting. You have a dog that's there's two options. Okay, so you have two big options. Either that dog is tachycardic because it's behind our body, or it's tachycardic potentially because it's painful. There are other things. So for me, if I'm like, gee, I don't know which it is, I don't want to give it something that's going to last hours, I will give it butorphanol because at like 0.2 to 0.3, because that for me is a proof of concept. If I give that and the heart rate comes down a little bit, I'm not going to keep giving it. Then I'm going to say, you know something, I need to address this dog's pain, if not done already. You can, because it has such a short pathway, if you're going to give it repeatedly, you can give butorphanol as a constant rate infusion as any opioid as well. But butorphanol in general is, I would use it in the cases like a laceration combined with dexmedetomidine. But by itself, it's a fairly poor analgesic. It's a nice sedative in cats as well initially. It gets a bad rap. It's not like the devil's spawn, which is what it gets a rap as because it's not the best of analgesics. But does that make sense? I use it because I'm like, wait a second. Because if you give it, and let's just say you give it and the effects are untoward. Because it's a partial, it's not going to cause anything horrific. And it goes away in 45 minutes. And I use it as I use the term proof of concept, if that makes sense. So listen, the thing is this, let's just do it. You have to remember though, is why you would never give this at the same, let's go through the other drugs that we know we'll go with. Fentanyl, FGH, fentanyl hydromorphone, fentanyl hydromorphone, morphine, which we don't use a lot of, but everyone else does. Naloxone. And oxymorphone. Well, not because any of you have got these in hospital who used oxymorphone. I miss it terribly, but we don't have it anymore. Okay? And so far, does that make sense? Why this is short acting when you can use it? Okay. So all of these down here are kind of the workhorses of us for pain relief, okay? Because they're mu agonists. They're not partial, these are pure agonists. So unlike a partial agonist lands, it will give you, in effect, a submaximal analgesic effect. Now, if you guys came in, they were talking about buprenorphine. And if you don't like the way buprenorphine, because it is a partial mu agonist, partial, so it's submaximal stimulation of that receptor. You can't, if you give it at a high dose, exceeding the dose in the textbook, say, oh, we gave it a 0.02 mg per kg, give it another 0.01. It doesn't work. It has a ceiling effect. You can only occupy so many of those receptors. And you're just pissing in the wind after that. Then we can say all of these are the same, right? These except this one. So fentanyl, we all know that one, right? Fentanyl, it's also mu. These things only act on the mu receptor, okay? And these are full agonists, okay? Agonists. And we did go through agonism and antagonism, what that means. So agonist. So this is, okay, we'll do this here. So these are the workhorses. These aren't partial anything. These are agonist, antagonists. These are all the workhorses of what we use in terms of their strength, of their power, in terms of what they do. Morphine is actually a mu and a delta agonist, if you want to know. That's the only drug that I know of that we use frequently. It also acts on the delta, which is it's in the spinal cord as well. But I don't think it's not really relevant. So, a couple of things with fentanyl, hydromorphone, and morphine, which we don't use a lot of morphine here. Things to know about morphine. It's the prototype. So when we look at the potency of an opioid, the potency compared to the potency is what dose in mg per kg do you have to give to get the same effect as morphine? And that's the term potency. And morphine is just arbitrarily given one. Morphine, it's a very good analgesic. It is we've seen this a lot. It's not always available, but it is associated when it's given intravenously with histamine release. And so animals do get urticaria, etc. I've seen animals get very, very itchy, and theoretically they can also get bronchoconstriction and stuff. Given IM, it doesn't occur. Morphine is associated in young dogs when it's given intramuscularly vomiting. In the older dogs, not so much. But we don't use it, I just haven't seen it all that much here, which is fine. We don't need to have all these medications. So then so morphine, we don't use it. I've not used it since I was here. I've used it a ton before I got here, but I don't miss it, especially. So then you get do you have my film? Ooh, that meant for the gods. Can't believe that. So, mu, it's a full agonist. Okay? So then we look at drugs like hydromorphone. This is a personal preference thing. So we talked about mu. Mu is responsible for all the good things about the opioids, right? The pain relief, relaxation. It is thought to do, in people it's described to cause almost like a dysphoria, a good dysphoria, like a euphoria. People should definitely feel euphoria on it. But remember we talked about so certain opioids like hydromorphone reset the thermostat. So they pant, they think they're hot, so they start panting, which I could do without. It causes fever, causes cats to become febrile, sometimes dogs as well. I use it very infrequently by itself. I'll use it with other drugs. It is an excellent, it's a great analgesic. I just find in animals that are younger, and not just debilitated, it causes a lot of things that I don't like. Fever, panting, agitation, that when I give that drug, for me personally, I look at what that animal is doing after I give it, and if I'm not sure what that dog is doing or cat is doing, I look at it and I'm like, shit, is that the drug that I just gave? Or is that the dog's disease? I worry about my ability to interpret what that patient is doing. Does that make sense? They get febrile, like loopy, and so I tend not to use it very much. I haven't used it in a cat in a very long time, but hydromorphone is more likely to cause the panting and the other untoward, sort of the dysphoria and vocalization types of things we will see typically in younger dogs. How do we avoid it? Well, when I was years, I gave 0.2 mg per kg. That's the published dose. So you don't write this down. I now give half of that, and it seems to work nicely. We start at 0.1 mg per kg and follow 0.05, which in general has made it less likely. I'm not bad enough from the drug. It's the preferred drug here. And I think if you're going to take a dog, put it under anesthesia quickly, it's fine. I just do not like watching them and get it, especially if they're young. However, remember, one of the other things to remember is I don't know why we arbitrarily give this Q6 hours here. Half-life doesn't allow, half-life doesn't support that. The half-life supports 4 hours to 6 hours, and I think that we should think about that a little bit with patients and not wait to give it at 6 hours. And if you're in a situation where it's really concerning, we should just put it on a CRI. Any of these drugs can be put on a CRI, not just the ones that we use. That's hydromorphone. So fentanyl, the fentanyl is the most rapid acting of them. It has the shortest half-life, but it provides analgesia pretty darn quickly. There are other things about it, but I think the relevance of it is we generally will give it. I'll use it intraoperatively if I have a dog that's waking up. Remember, we're not going to give it people quiet. So we have a dog that's waking up. Someone says, hey, I have buprenorphine or I have fentanyl. Which would you give it?
Fentanyl.
Right. Why not buprenorphine?
Because you said it takes buprenorphine a longer time.
Correct. So you give that dog under anesthesia, buprenorphine, to cut back on its anesthesia. Bad move. Why? Because it takes 15 minutes at a minimum, closer to 30 minutes to achieve any analgesia. So fentanyl is the one that we would preferentially use. I think what else? Okay, so what else about these things? So we've got everything else. Okay, so fentanyl, rapid onset, short duration, which is why we give it as a constant rate infusion as a general rule. And so morphine we spoke about, and methadone. So methadone, you might be, when you tell physicians that you're using methadone, it's not used as we use it. Methadone is used for people coming off of opium and heroin. And not that it's not used for that, but it is so close in structure to heroin. It doesn't have the same effects. But there's, for me, full disclosure, if it weren't for the cost of methadone, I can't think of any reason why it's not used in any or every patient. And I don't get any kickbacks. I've been using it for 15 years, and so why do I like it? Because it's less likely to cause. I've never seen it cause the panting or the other things. It does cause animals to poop like other opioids, but that's the worst adverse event I've ever seen with it. I do not find that it has the same respiratory depressive effects or the same dysphoric effects, the vocalization, the panting, the agitation, the fever that is seen with hydro in younger animals. The other thing, if you ever used it, it's a really easy onset, really easy offset no matter how you administer it. Again, hydromorphone and methadone, again, Q4 to 6, and you can give it as needed. It depends on the patient. And so when we use methadone, I'm not sure where we get the doses from. I see doctors using 0.1, 0.2 mg per kg. It's not, unless I had a really geriatric animal. So typically, if I'm pre-medding a dog, I use 0.7 mg per kg. It's a lot of fucking money, It's a ton of money. But generally, if I'm really want to provide analgesia for a dog, if I'm mixing it with, let's say, ketamine and dexdomitor, I'll use 0.2 mg per kg. But really for analgesia, and I'm trying to use it I'll use 0.3 mg per kg, or 1 milligram per cat is usually pretty effective. And so I think that if you use other drugs, it's great. However, I mean, those of you who work with pets on methadone, I'm welcome to have discussion. It works beautifully. And in dogs, cats is the ones, I'll tell you that I think cats do great with buprenorphine if it's in their system first. And cats if you've ever seen a cat that's on buprenorphine, they look super happy in general. And I'm not saying you should stop antipromorphic, but those animals on buprenorphine, cats, their posture and their ears and their facial expression would suggest that they're fairly well analgesic. The other thing about buprenorphine that I just wanted to talk about is that we do have a product here called Symbidol. So there's a company that makes something called buprenorphine XR or SR, sustained release. The reason that lasts 48 hours. The reason we don't have that is because it's not made by any specific manufacturer. When you get it, it could come from Tampa, Florida, or come from Taiwan. And there's just a sense that the quality control is not that great. But we do have Symbidol, and that is a 24-hour analgesic in cats. The key is this, that people, it does not matter what you induce that animal with. You could have induced the animal with buprenorphine, or butorphanol, or methadone, or anything else. The beauty of it is it's easy onset, easy offset. So if you give to a blind cat, it oops, I use methadone, and it's okay, because the methadone will wear off in time for this to kick in. And as those who work with me, and I always ask the nurses, like, do you agree with me? What do you think? Symbidol, don't they feel great?
They love it.
They love it. And the other thing about that, I'll tell you about it, it's the dose on the bottle is 0.24 mg per kg. That's enough for a small elephant. And so the dose is, so we don't use that with zero, it's on the bottle. I've never used that dose. It's 0.18 mg per kg. And it works beautifully. And cats, and you just walk by, like German shepherds walk by barking, and the cat's like, hey. The cat's okay, and it's pain-free, and they're happy, and they're content, and they purr, and they roll around, and they eat. And it lasts 24 hours. And so I find I really, really embrace that, even for very, very painful things. I know that ortho, but it really works very nicely. Okay, so methadone, IV, IM, sub-Q, all of these by any route. Fentanyl, give it IV, but all of them are safe by any route. So then, these are all things that help us out. We give them all for pain relief. And bear in mind, even none of them are supposed to last up to 6 hours. So we should really either maybe kick up the dose or at least have some more evaluation before we put everything in 6 hours. The other drug I want to talk about, so we said, check this out. So we said, these are all agonists, partial this, partial this. Then we come down here, and this is a drug called naloxone. So what receptors does it work on? It works on mu and kappa. But guess what? It's mu because what do you think it does to mu? Antagonist, agonist?
Antagonist.
Yes, good. So remember we talked antagonist. What about the kappa? Antagonist. That's exactly right. So what this is, we use this as a reversal agent for overdosing animals. Okay. So have you ever heard of naloxone? You keep it, or Narcan. So that's what they. Okay. Diarrhea, because one of the effects of the opioids is to slow down motility, and perhaps the people and everyone else. So drugs like Lomodal and drugs like Imodium are attenuated opioids that are used for diarrhea because we take advantage of the fact that they stop smooth muscle motility.
In the textbooks that I teach, it says that it can have the onset of diarrhea at first, but then go into constipation. Why is that?
Well, that I don't know. Because
Okay.
it affects smooth muscle. But it also, I can tell you, initially it causes vomiting because it affects the chemoreceptor trigger zone. But acutely, if you notice, so what it does is, I don't know what it does, but it's like we see animals all the time when we give them an opioid and they're waiting to be sedated and they poop all over the floor. I'm not sure what's going on there.
Okay.
And they don't, but the thing is, they don't reliably get constipated. Everyone knows how I feel about fennel patches. It's not a secret. I think they're very constipating in dogs and cats. But otherwise, the doses we used them for. But I'll tell you, we have enough animals where they're like still nauseated and they feel crappy after surgery. When you pull them off fentanyl, and 4 hours later they feel a lot better. So I don't think we should ever discount that. And now that we have other combinations of analgesics now, ketamine, dextrose, ketamine, lidocaine, if an animal's not eating and they're earthy post-operatively, I'm a lot more and likely to back off their fentanyl as a reason for their not eating. Because it really does cause, I think it does cause ileus in some ways with fentanyl. And the other drugs, how about this? You know what else? There's other drugs too that are opioids. One of them is tramadol.
Mm-hmm.
So tramadol that's really funny because I call it tramadol. I think it's a classic drug. But so tramadol is 4 different mechanisms of action. So it's an NSAID, it's a codeine derivative, but it's also a serotonin norepinephrine reuptake inhibitor. However, the reason it doesn't work in people and some dogs is because not everyone has this. It's a small amount of us have the enzyme to convert it to its active. And it's the same thing in dogs. It works great in cats, but the tramadol would be considered an opioid as well. And we used to use it all the time. And so I think that is pretty much, I made some little notes, advantages, naloxone, yeah. And then the other thing is I just want to end with just definitions because it's irrelevant in people. So what's the difference between tolerance to an opioid and dependence on an opioid?
Addiction, or your body's need for it. It builds up receptors and needs it.
Yeah, I was gonna say dependence means you can't function without it, whereas tolerance means you need a higher level of it to achieve
Exactly.
the
So
dependence.
tolerance means that there's a decreased effect over time using the same dose, but over time you get a decreased effect despite maintaining the same concentration of the drug. So exactly. So dependence means when generally after an animal or a person has been on a drug for a very long time, following withdrawal of that drug, they will result in like both physical and psychological effects. And so I think that is where I'll wind up. But I know this is a lot, but I hope that this is helpful. Again, if there's something that's not clear, you need to let me know. Like, honestly, if there's something I said here, I know I need to know because I really wanted to make this something that was you looked at go, hey, and most of it is textbook, some of it suggests my own crusade against methylmorphone is not valid. Any questions? Stefan, you tell me that it's not clear.
No, I think it's broken down very clear. Star, what do you think?
Yeah, start.
I was just reviewing my notes to make sure that I understood everything, but yeah, I think I understand it.
There's
How
a part of
you
it that's
explained
not, it would help me, because if you ask me, then I'll know it's not just you.
Yeah,
Other people, but if you want to ask me a question about something I said, then
Yeah.
or you can ask me later or here, I'm not trying to put you on the spot, but it's very important to me to be able to communicate this
yeah,
on a level that is understood by all, and helpful.
So also what we did is we have video record it. We are going to post it to our YouTube station, and then people can ask questions to that, and then I can surmise the questions and represent it. And maybe when we do a follow-up class, we could answer those questions.
Yeah, I think you broke it down really well, though.
yeah, I understood all of it, I did,
Okay.
I'm not lying.